Yeah, hello. Good evening, sisters.
Good evening.
Good
Good
evening.
evening.
How are you?
I'm doing well. I hope you're also doing good.
I pray.
Yes.
All right.
Yes, sis.
All right. Okay. So, please let's start. Unfortunately, maybe we may have to close a bit early today because I need to join the master's class for some presentations. Okay. So maybe when it's around maybe 6:20, we may have to end the class and hopefully continue, God willing, tomorrow. Okay. So yeah, so with regards to, I think I've shared this notes, that is this lecture note with you. So please, if you know you haven't seen it, kindly check it on the Telegram page. Okay. So basically, like I said, I've already gone through maternal mortality with you, but then because I wanted us to look at, that is emergency obstetric and newborn care, I just decided to bring it back, and then so that we'll be able to have a good discussion why it's necessary for us to look at emergency, especially in management, in terms of its management. So I'm not really going through these ones with you. That is the maternal mortality. Please read it. I'm begging you, read it on your own so that we can save a bit of time. Okay. So rather, I want us to look at that is specifically the EMOC, that is the emergency obstetric and newborn care. Okay. All right. So first of all, let's look at some definitions of terms. Please, those of you disturbing, can you be mindful of your, please be mindful of your microphone. Okay. All right. So let's start by looking at emergency, because we are dealing with emergency situations, because in our part of the world, what it has that is findings, or most research have seen, that is all, have identified that most of the cases, or why maternal mortality and morbidity is always high, has to do with our management, our ability to manage complications, and especially emergencies, which has always been the case in our hospitals. Well, due to a whole lot of factors, I always say the issue is always multifactorial, because unfortunately, these women will not, or may not, report at the facility on time. So by the time they come, or by the time they report, it's like that is everything has to be done in an urgent manner. Other than that, either the mother loses her life, or both the mother and the baby, or that is, yes, both the mother and the baby lose their lives. Please just, yeah. Okay, so emergency, that is the term emergency means sudden crisis requiring action, or an immediate or a sudden event that must be dealt with urgently. So it means that when we say emergency, it needs an urgent attention. Then obstetrics, we know obstetrics. So it's a branch of medicine that specializes in the caring for women during pregnancy, labor, and immediately following childbirth. So the neonate, you know what a neonate is, who a neonate is. Then we have care. So it's just to break down this that is emergency obstetric and newborn care for us to really appreciate it. Okay, so together we are saying that emergency obstetric and newborn care is identified as a set of life-saving interventions. So they are basically life-saving interventions that treat the major obstetric and newborn causes of morbidity and mortality. So to assess the level of care, these functions are classified as either basic. So we have two classification, or it's been EMOC is being classified into two. So we have the basic one, and then we have the comprehensive one. So for the basic emergency obstetric and newborn care, so in the first place, we have to know that it's just, when we say EMOC, it's just a life-saving interventions, because I've already explained that due to most of the cases that report to our facilities, because there is some form of delay. And please, we've already learned, or we've already discussed delay, that is delay in access, that is in accessing care. Okay, so most of the time before they report, it just require an immediate or an urgent attention. So for the basic one, it's a primary health care level initiative promoted in low and middle income countries to reduce maternal morbidity and mortality, that is maternal and then newborn. So basically what here it means for the basic means, just as the name implies, at least for the basic levels, primary healthcare facilities, these set of interventions or life-saving interventions should be available to at least provide the minimum care for the mother and then the newborn for their survival. Okay. So, so for the basic, that is for the basic ones, facilities provide 7 signal functions or life-saving obstetric services. So the signal functions is also known as the life-saving services, that is obstetric services, and they include parenteral, that is administration. I think I've outlined them also here. So administration of parenteral antibiotics to prevent puerperal infection or treat abortion complications. Then we have administration of parenteral anticonvulsants. So at least at the basic level, please. Those who are not listening and are just talking, who is that? Belinda or Rebecca, please. I keep telling you that please be mindful of your mic. As for you doing your own thing, that one I can't stop you, but at least just be mindful that and often check your microphone so that you don't disturb us. Okay. So we have the, that is anticonvulsant, parenteral anticonvulsant. We have administration of parenteral uterotonic drugs for that is for PPH. Then manual removal of the placenta, assisted vaginal delivery, into bracket vacuum extractions. Then we have removal of retained product of conception and neonatal resuscitation. So at the basic level or at the primary level, these interventions should be able to go on, or that is the skilled birth attendants there should be able to provide these interventions or management to a mother and her newborn for survival. Okay, then we have the comprehensive, that is the comprehensive emergency obstetric and newborn care. So basically that one includes the signal functions. So I've told you that the signal functions, they are 7, and they are the basics. They form the basics. So the comprehensive one is a signal function, that is the 7 signal functions plus cesarean section and then blood transfusion. So making it 9. That is 9 at the comprehensive EMOC. So you could see that for the comprehensive, it means that that one could be performed or at least at the higher or at the tertiary, that is the regional facilities, even at the district facilities. These interventions should be able to, that is the woman should be able to assess these interventions, or there should be, we should be able to use these interventions to help the mother and the newborn to survive. Okay. So like basically I said, the background to the IMOC or the implementation or the initiative of IMOC has to basically do with the increase or the high rate of maternal and newborn mortality. So the principles, that is principles underlying IMOC, is to provide knowledge on basic and comprehensive life-saving measures to avert maternal and neonatal death and disability. Two, to influence in a positive way the attitude of health personnel towards teamwork, because some of these interventions, you actually need a team to work with. So be able to call for help where necessary. Okay, then we have number 3 says to use recommended infection prevention principles for every patient. Number 4 says to provide interpersonal communication skills needed to respect the right of women to life, health, privacy, and dignity. Already we've also tackled respectful maternity care or maternal care. So, so somebody is now asking what is IMOC. Okay, I think, like I said, I shared this notes yesterday. So sometimes I am when you fake akra. I shared this yesterday. So why are you now asking? And even I've started already. Why are you now asking? Anyway. And then the next one is to work hand in hand with the community, non-governmental organizations, and other stakeholders in responding effectively to IMOC. And please, I don't know, but let me pass this across, because some of you, I think some intention is like, oh, we are just joining, and then maybe even if we read or we don't pay attention, that is when it's lecture time or the rest, there should be some favor. Please, I don't know what to say, but once you've made up your mind to do the top up, I'm begging you. I know how difficult it is. It's not easy. I've experienced it and I know it's not easy. But sometimes, please, let's make time. Let's make some small time once we've registered and we've paid school fees. Please, let's make time, and then whatever materials or whatever that is, be active during learning or during lecture hours. And we shouldn't let it seem as if like we just come in at any point in time and it's like you don't even know what is going on. Okay, so let's look at, so we have also 6 indicators. So 6 indicators, that is indicator number 1 says that for every 500,000 population. So for the IMOC indicate, that is for IMOC is actually targeted at every 500 population. So for every 500 population, at least there should be these intervention being instituted so that there can be early or urgent care for the mother and then the baby during, that is throughout the pregnancy, the delivery stage or the labor and delivery stage, and then the postpartum phase. Okay, so IMOC is always targeting at least 500,000 population. So let's say, for instance, maybe at a district level or maybe at a community, having about 500,000, or maybe, yeah, in a health facility that supplies around 500,000 population. So once at least we can number around 500,000 population within a community or within a district, there should be availability of this intervention or provision of this intervention to the survivor, or to help with the survival of the mother and then her baby. Okay, so one is that for every 500,000 population, there should be at least 4 basic and 1 comprehensive UMOC facility. So please, the one disturbing, can you? Okay, so yeah, so at least there should be at least 4 basic and 1 comprehensive UMOC facilities. Okay, then indicator number 2 says that UMOC facilities should be well distributed to serve the 500,000 people. So at least it should be fairly distributed. So it's not that maybe you go to some community, though they are 500,000, but then they don't have access to these kind of life-saving interventions, or the facility, there is no even that is a facility to even serve them or help them with these interventions. And so that's why there is the more reason why these CHIPS compounds were all over, so that even within every community, there can be a health facility, or at least a facility that can serve a purpose, especially with the basic, that is with the basic emergency obstetric and newborn care. And then the indicator number 3 says that at least 15% of all births in the community take place in UMOC facilities. So 15% of it should, at least of all births, they should be able to assess skilled birth attendance. There should be they should be able to assess or that is facility birth. The indicator number 4 says that at least 100% of women with obstetric complications should be treated in UMOC facilities. And then indicator number 5, there is the one who said I should make you co-host. I don't know. Can you just help? Okay, let me see if I can do it here. Yeah, I'm not sure how I can do it.
With me, let's go.
Okay, all right, okay. Yeah, it seems please, can you indicate? Okay, all right, thank you. Make co-host, okay, all right. Yeah, thank you. Okay, then number 5, as a proportion of all births in the population, cesarean sections should account for not less than 5% or more than 15% of all births. Then the last indicator, which is indicator number 6, is the case fatality rate. In case fatality rate, the proportion of women with obstetric complications admitted to a facility who die, maximum level should not exceed 1%. So sometimes I remember when I was going through it, I asked myself a lot of questions, especially in our setup here, whether we'll be able to at least control, put in measures to control some of these things, so that at least that here is saying that at least even in a case fatality rate, that is the case fatality rate that can be recorded should not even exceed 1%. Okay, so UMOC framework. So the framework is basically that is how each nation. So basically, what they do is that because it's a global or worldwide intervention, normally individual nation or country should adapt it, and then assessing the situation within your country or your nation, you know how best you can go about implementing it. Okay, but the IMO, so it says that IMO framework is a national framework on ways of handling emergency obstetrics and neonatal well-being. That is, for instance, if I don't know whether some of you have been engaged in that training, that is the Helping Baby Breathe or Help the Baby Breathe program, which was run by, I don't know whether it's still ongoing. Okay, so let's look at the model, the IMOC service model. So per each district is saying that each district is supposed to have both basic and comprehensive IMOC services. So within each district, there should be, so that's why there should be a district hospital, there should be a polyclinic, there should be a health centers, and then in the remote or that is within the sub communities, there can also be chiefs compound to help where they can all provide these services or interventions. So per 500,000 population, there should be 4 basics and 1 comprehensive IMOC services. Okay, then recommendations for basic IMOC. I think that one we've already made mention of it. That is the service area signal functions, which is also known as a life-saving measure. So these are just 7 measures that at least within the basic emergency, these should be able to, there should be availability of these, that is parenteral antibiotics, oxytocins, and the rest to help, especially in case of PPH, in case of infection, in case of preeclampsia, or when the mother is having an eclampsia and is fitting. And then manual removal of the placenta, there should be provision, that is these, which means that these facilities should be well staffed, or they should be well, that is most of the equipment that helps with, that is medications and equipment, it should be well, that is should be available to provide all these services or all these interventions, including neonatal resuscitation. Okay, so at the basic level, like I said, we have the health centers and then the hospitals. And then in terms of skilled attendants, there should be at least midwives and nurses with midwifery skills, then other supporting staff. So especially at the health centers and then the chief's compound, there should be at least midwives or a nurse with midwifery skills and other supportive or supporting staff to help assist the midwife in cases of emergency. Then another comprehensive one, so like I said, the 7 signal functions plus 2 basic, that is 2 other functions, which is blood transfusion and cesarean section. So which means that here with a blood transfusion, it means that there should be a lab, there should be a blood bank, a lab, and then with a cesarean section, it means that the facility should have a well-equipped operating theater or operating room to help with emergency cesarean sections. So another comprehensive one setting is hospitals, that is basically from the district hospitals upward, that is the district hospitals, the regional hospitals, and then the tertiary, which is the teaching hospitals. So hospital with an operating theater and surgical capacity. And then in terms of skilled attendants, there should be a team doctors, clinical officers, anesthetists, because these ones involve operation, midwives, nurses, and supporting staff. Okay, so under it too, we are looking at management of shock according to the IMOC general management. Okay, so according to the general management under IMOC, It says, first of all, when maybe in case maybe a woman is having a PPH or in case of ectopic pregnancy and the woman is going into shock, the first thing is to shout for help, to urgently mobilize available personnel. So you should shout for help. Then you should greet the woman respectfully and with kindness, especially if the woman is a little responsive. Then if the woman is conscious and responsive, tell the woman and her support persons what is going to be done. Listen to her and respond attentively to her questions and concerns. Then provide continual emotional support and reassurance as much as possible. Then with the immediate management, because this person is into shock, you have to nurse or you have to manage the person in a conscious, that is in a semi-conscious state. So here you have to turn the woman into her side and ensure that the airway is open, so semi-prone position. If the woman is not breathing, begin resuscitation measures. And then check the woman's vital signs, that is the temperature, pulse, blood pressure, and respirations every 15 minutes. So basically what we do is that you monitor every 15 minutes for the next 1 hour, and then afterwards, depending on the condition, then it can be 30 minutes every 1 hour. And then as the condition improves, you can then monitor the patient every 2 hourly, and then on as the conditions improve. So give oxygen at 6 to 8 liters per minute by face mask or nasal catheter. Cover the woman with a blanket to ensure warmth, but do not overheat. Do not overheat. In the absence of the non-pneumatic anti-shock garment. So this one was actually invented by, I think it was UNICEF. Yeah, UNICEF that, and then even the UNFPA. So they were the ones spearheading this one. So in case it's absent, and we as we go on, we will know what it does. That is the non-pneumatic anti-shock garment. So here, if it's absent or your facility don't have, what you have to do is that you elevate the foot end of the bed, and then elevate the woman's leg to increase return of blood to the heart. So if possible, raise the foot end of the bed. So below is the shock. So this is this is a picture of it. So there's a midwife helping the woman with the anti-shock garment. That is the non-pneumatic anti-shock garment. Okay. So what it does is that the end, that is the NASAC, actually that's a short form, say that it reduces, what it does is that it reduces blood flow to the uterus and treats hypovolemic shock. So it can keep a woman with PPH alive for up to 48 hours. So for the next 48 hours, when you are able to apply, or you are able to help the woman into this, the non-pneumatic, that is the anti-shock garment, is able to keep the client alive for the next 48 hours, because what it does is that it reduces blood flow to the uterus, and then help treat hypovolemic shock. Yes, Justin. He's the one who's oh, it's a mistake. The one with the hand up. Okay. So this, so without it, she may bleed out within 30 minutes. Okay, so this buys critical time to transfer a patient to healthcare and provide treatment. So basically, this is really important, especially at the primary healthcare facilities where maybe there may be a need for referral. So, but before you refer the woman, you can put this one on to save the life of the woman from dying. Okay, so yes, hello, is somebody talking? Okay, so it is also lightweight, so it's not heavy, washable, and it can be reused up to 144 times. So in case a hospital has one, I don't know if any of you have one in your facilities. So it's saying that it's washable, so you can reuse it several times for women. Okay, so let's look at the mechanism of action for the NSAC, that is the NASAC. So the anti-shock garment reverses shock by shunting blood from the lower extremities and abdomen to the heart, brain, and lungs. It reduces blood loss because it compresses the blood vessels. When the radius of the blood vessels is decreased, blood flow through the vessels decreases. So collect blood using antiseptic method. So once you've applied this one on, you need to also take blood sample for grouping and cross-matching hemoglobin to also determine the hemoglobin level, and then the clotting time. And then the clotting time. Okay, and then the clotting time. Then you have to cannulate 2 large bore cannula 16G and commence normal saline or Ringer's lactate and adjust tubing to run fluid at a rate sufficiently rapid to infuse 1 liter. So within 15 to 20 minutes, 1 liter of either normal saline or Ringer's lactate should run. Then for women with uterine atony, so you start another liter of saline with 20 units of oxytocin. So you put 20 units of oxytocin to run at a rate of 30 to 45 drops per minute. So if the woman is not breathing, or not breathing well, perform endotracheal intubation and ventilate with an ambu bag. Then bladder catheterization is also important, and indwelling. So basically it's to help you monitor the output, that is the urine output, because already you need to run infusions very fast. So you also need to monitor the output. Okay, so this is just the summary. So in summary, the IMOC refers to the care of women and newborns during pregnancy, delivery, and the time after delivery. So it is offered at 2 levels of healthcare. That is the basic, and then we have the basic services at the health centers, and comprehensive IMOC services at the health institutions where they have theater facilities, and also where there's lab or blood bank facility. Then I said the aim of IMOC is designed to train doctors, nurses, and midwives, and then other clinical officers to help prevent, that is, maternal death and disabilities. Okay. So please, up to this point, is there any question? Because I don't know if we can even start this one and finish. You said? Okay, so like I said, let me quickly introduce this one. Maybe they are just calling me. So maybe when it's exactly 6, we'll close. So let me introduce. So the next thing that we'll be looking at is maternal mental health. So maternal mental health is very important, but I think that in our part of the world is also something that I think much attention is not being paid. Okay. And we really need to pay attention to it in our facilities. And then, so I remember it was only, I don't know about other facilities, but I remember I went for some clinicals at Menchia, those in Kumasi, Menchia Hospital. So that was where they have this community psychiatry. So I realized that they have clients who are also, who are postpartum mothers or even pregnant women, and they also come for treatment and all that. All right. So as a way of introduction, so first of all, look at postpartum. I think that's what basically we will focus on. So we will focus on, I will mention other mental health conditions within that is maternal health conditions. But then basically we'll focus on postnatal depression. We have postnatal and then the postpartum depression. So postnatal depression is a global public health problem with a prevalence rate between 13 and 19%. So you can see that it is a call for concern. So it is defined as So it is defined as a major depressive disorder in the year following childbirth. That is in the year, meaning that is 12 months or 1 year following childbirth, and is one of the most common disorders of the postnatal period. So let's look at the risk factors. So risk factors include environmental, psychological, and biological factors. So it may be due to environmental factors, psychological, and then biological factors. So it is associated with a range of diverse outcomes for the woman and her child. And health professionals, that is, as midwives, we should be able to help families, that is, families during this period, to be able to identify women with the postnatal depression and support them to access treatment, because these mental conditions, they are treatable. So, or they should be able to access appropriate treatment in order to reduce the burden of, of this disorder. Okay. So you look at the epidemiological and then a theology, that is the causes of postnatal depression, as well as that is the overview of that is the evidence-based practices that is available, and then the clinical guidance for identification, prevention, and then intervention. Okay. So basically, what the literature also let us know is that much as most of the time, maternal depression, and the focus is mostly on maternal depression, especially during childbirth or when after the woman has given birth. Normally, these kind of psychological or mental illness also affect the family so much, because this woman is with a newborn, and the immediate person that normally also affects the person psychologically or mentally is also the father. So normally we have what's called a paternal depression, also associated with diverse adverse outcomes for the man himself, So for his partner and also for his baby. So mostly these are also, so that's why when we are taking care of them, we don't only focus on the woman, but then we help the entire family out of this condition. Okay, so there we have the definition, but like I said, already it's 6. So let me end here, and then like I said, we will consider maternal depression. So God willing, tomorrow we will continue with the definitions, the various definitions, especially under the maternal, that is the mental health, under mental health, and that is the DSM, under the mental health, the diagnostic criteria, and then in terms of prevalence, we will look at the key risk factors of postnatal depression, and then we will also look at the intervention in terms of identification, and also that is, we have assessment as well, and then how we may be able to help prevent this postnatal depression, and then the available intervention that we also have to look at. Okay, so let's continue, God willing, tomorrow. But then before then, in case anyone has a question, especially with the IMOC, you can ask your question. But like I said already, I've posted it on the Telegram. So please kindly download it. Kindly download it, and then kindly download it and read it ahead of time. Okay, thank you. I think I saw a hand. Okay. All right. So if there are no questions, then please let's meet tomorrow. I think we can use produce time. All right. Thank you.